And Ravi gave an excellent introduction and talk, and I think some of our material will regrettably overlap, but I think that's also a good thing to reinforce some of the similar concepts that I think we share, these disclosures. So when do we start renal replacement therapy in acute kidney injury? I think that's the key question that I was asked to try to resolve for you. And I would argue right now that the optimal timing of renal replacement therapy initiation in critically ill patients with acute kidney injury is largely unknown. I think there's a paucity of randomized trials that's looked at this currently, and I think the observational data we have are unfortunately at risk of bias and confounding by indication. There's no real consensus that guides clinical practice in this area, probably because of the evidence base, but what this is translated into, in essence, is wide variation in practice on how we go about initiating renal replacement therapy for our critically ill patients. And I would argue as well that I think this is a critical knowledge gap in our understanding of how to support these really, really sick people. And we need better evidence. And why is that more important than ever? I think it's more important than ever because this is some data from my colleague Ron Wald in Ontario, Canada, that's showing that we are now using more renal replacement therapy. And there have been other observational studies that have shown the same thing. There are temporal trends in the last 10 or 15 years to suggest that we are applying this technology more commonly to our critically ill patients. Hence, we're treating more patients, so it's more important than ever for us to understand when to optimally initiate therapy. I would also argue that this is not a new question, and regrettably it wasn't answered 50 years ago adequately enough for us to inform our clinical practice today. But this is a long-standing question that a lot of us have been trying to get to the bottom of. The recent KDIGO clinical practice guidelines offer two real statements around initiation of renal replacement therapy. The first is, initiate it when there's a life-threatening complication attributable to acute kidney injury. I think everyone in the room would agree with that statement. Although it's not supported by robust evidence per se, if a patient has a life-threatening complication that you feel is imminently treated with renal replacement therapy, I don't think anyone here would have equipoise not to treat such patients. The second statement is a little more vague, if you like, but importantly, it really gets to the heart of the issue, which is we don't have a lot of robust, high-quality clinical evidence from randomized trials that are guiding these decisions for us. So it really states, consider the broader clinical context, the presence of conditions that can be modified with renal replacement therapy, trends in laboratory tests rather than a single indication or laboratory test, if you like, when making the decision. And you'll notice not graded. Again, we have a paucity of data around this issue. There have been a number of surveys that have sort of, asked clinicians, tell us about what you do at the time of considering renal replacement therapy initiation. And I want to sum up these three surveys for you very quickly. The decision to start renal replacement therapy, because of the prevailing evidence base, is largely subjective. It's based on the spectrum of clinical information that providers get and their own intrinsic bias. Providers start when confronted with life-threatening complications. So across these surveys, if a patient had hyperkalemia that had evidence of cardiac toxicity or a perception that it was going to cause harm, there was no question providers initiated therapy. There was wide variation amongst providers in what was considered the minimum severity of an indication to prompt the initiation of renal replacement therapy. And importantly, there was a lot of other modifiers of the decision besides simple serum creatinine and urine output. Some of these factors included things that Dr. Mehta had got to before, but patient age, patient comorbidity, responsiveness to a diuretic challenge, overarching illness severity of the patient and trajectory of organ dysfunction. But there are other intangible factors as well that we have to remember. So one is the prescribing service, whether it's critical care or whether it's nephrology. And importantly as well, the time of day and the day of the week. Believe it or not, in one of our surveys, it was clearly evident that if the decision had to be made at 4 in the morning on a Sunday night, it was likely to be referred several hours regardless of what the complication causing the decision to be made was. So clearly there's a lot of other modifying factors that go into this decision about when to initiate. Hence, it's fairly complex, as Dr. Mehta got at. So these are the so-called classic indications, and similar to the table that Ravi showed, and I would argue that I'm sure that Professor Ronco has put this in some slide somewhere, but any textbook of critical care and nephrology for the most part will have a similar table like this. And I think for the most part, if you're confronted with these indications in a sick, critically ill patient who's ventilated on pressors, etc., you're likely to initiate renal replacement therapy. But what I want to get across to you, and I think is important, is that those life-threatening complications are less commonly encountered now in critically ill patients. The immediate indication, because we perceive it to be life-threatening, is not the primary reason or the most predominant reason we are initiating renal replacement therapy in the ICU. And this is some data from a multi-center study we did in Canada that basically shows that these so-called classic life-threatening complications are far less common. We are more likely to initiate renal replacement therapy in circumstances of hypoxemia that's attributed to fluid overload, relative oliguria, or fluid overload in and of itself, despite 3/4 of these patients having rifle category failure or stage 3 KDIGO AKI. So it's important then to consider what are the pros and cons when we're talking about initiating renal replacement therapy, the benefits to earlier versus the risks to earlier, and weighing those risks. Well, what are some of the benefits? We've heard a little bit about this, about considering maybe earlier or preemptive renal replacement therapy. Well, you're better able to achieve azotemic control. You're more likely to achieve electrolyte and acid-base homeostasis more quickly, fluid balance homeostasis, which we've heard a lot about already, and you may be more likely to prevent overt complications of AKI occurring, which we've heard can have an attributable mortality, and I'll show you that slide again. But what are some of the risks? And I think some of these risks need to be balanced out as well, right? We have to put in a dialysis catheter. We connect the patient's blood to an extracorporeal circuit, which you could argue is a fairly invasive procedure. We often have to anticoagulate them, and these have their own intrinsic complications. We actually subject patients to micronutrient depletion and/or depletion of other drugs that are vital that we give to them. It does add resources to the bedside for these patients, makes our nurses busier. And we always run the risk that we initiate renal replacement therapy unnecessarily when patients may in fact have recovered on their own with no ill sequelae. So the balance of the decision to start really is based on indications and the perception of whether the benefit will be greater than the apparent risk or harm. And I want to reemphasize this slide again. I think this is one of the nice studies that have come out in the last year that really gets to the heart of the idiom that I think John Kellum had in the opening address to the Congress that says, look, patients are not simply dying with acute kidney injury anymore. In fact, this data would suggest they're dying of acute kidney injury. So here you see the incremental mortality attributable to the complications developing in acute kidney injury. And in those patients who received renal replacement therapy, amongst those that had acute kidney injury, survival was better if they'd had a complication, right, versus if they did not receive renal replacement therapy. Hyperkalemia, metabolic acidosis, fluid overload, azotemia, etc. These patients all seem to do a little bit better. Alternatively, however, how would too early of initiation of renal replacement therapy potentially be detrimental? And there is a number of mechanisms by which this may, in fact, impede or impair the natural repair and recovery processes of the kidney if we're not careful on how we do this. Maladaptive neurohormonal adaptations to renal replacement therapy in and of itself. How many providers in here have started a patient on continuous renal replacement therapy who was making about 500 or 600 mils of urine a day, and then within 6 hours they're anuric, right? And you're on that course for good for now. Secondary iatrogenic hemodynamic insults. This is a real barrier to recovery to some extent, and if we induce injury that's iatrogenic attributable to our therapy, then we likely are to increase or decrease the probability of recovery. Membrane-induced inflammation and blood exposure to an extracorporeal circuit despite being biocompatible. And then, importantly, I think, is when you think about the marginal indication. So if we're exposing a patient to renal replacement therapy in the setting of a marginal indication, and there's a high probability of recovery, we may disrupt that process. And I think we need better evidence to help us sort out when that might be. There are a number of observational studies that have looked at this very issue about when to optimally initiate renal replacement therapy, what factors in particular may be associated with early versus delayed and mortality, etc. And on balance, they either show that there's really no association or there may be a slight association with improved survival for earlier initiation of renal replacement therapy. Again, though, this is all based on observational data. And these studies are certainly at risk of bias. They're often secondary analysis of randomized trials. They're retrospective cohort studies. And they're certainly biased and confounded by indication. I do want to reemphasize this study again by the Finaki group. It was a fairly elegant study. Again, though, secondary analysis and observational in nature. But 239 patients in this study with AKI, all treated with renal replacement therapy. They looked at timing again relative to the evidence of developing one or more conventional indications or classic indications for renal replacement therapy. It was either preemptive, in which no indication existed, or it was classic urgent, and I'll show you the classic indications again, but basically within 12 hours of that developing or delayed. More than 12 hours transpired after they developed that complication before renal replacement therapy was initiated. These were the conventional indications as defined in the study, which we've largely seen to some extent, and some of these would deem to be, potentially life-threatening, if you like. And what was really interesting is they looked at 90-day mortality, and amongst the group, when you compared the preemptive versus the classic groups on whole, you can see that the preemptive group had a much lower 90-day mortality. Similarly, if you look at just those that had a complication, right? A classic urgent versus classic delayed, and those that had their therapy delayed at least 12 hours beyond the development of that complication, they had a higher observed mortality. In fact, quite high, 68%. And you can see the odds ratio there. And then they actually also compared preemptive versus patients who had no renal replacement therapy altogether. And this is a very interesting group because this gets around the whole idea about whether we should or should not initiate renal replacement therapy altogether, not when to do it. And this suggested that the preemptive therapy, although this analysis is somewhat limited, actually seemed to have a survival advantage. Again, with all the caveats that go with observational data. There are, as I mentioned earlier, there's been very few randomized trials that have looked at this issue, and certainly Catherine Booman's trial is one of the trials that sort of stands out. This was a small two-center trial of just over 100 patients, predominantly undergoing cardiothoracic surgery, and they defined early renal replacement therapy as starting within 12 hours of fulfilling eligibility criteria. Late was basically, they had ureas that were in excess of 40, had a life-threatening complication related to hyperkalemia, or developed, in fact, pulmonary edema. And in their study, they did not find any statistically significant difference in survival between the groups. But you can see they did get separation in terms of early versus late start. So approximately 7 hours in the early group versus 42 hours in the late group. And what's interesting to me in the late group is you see that 6 ultimately did not receive renal replacement therapy. Right? So these are patients that either died or recovered. But amongst those that did, about half of them actually had high ureas, and this was the trigger. But another half actually had complications related to fluid overload and pulmonary edema. Again, this is a common theme that we've seen, that fluid and fluid accumulation, again, being a more prominent trigger for renal replacement therapy. But as mentioned, this trial was small, likely underpowered, had very high survival overall compared with other trials at the time, and was predominantly done in cardiac surgical populations. So, our belief is it may have limited applicability to broader populations of critically ill patients. And one of the challenges we have is, where are we here? Where are we on this graph when we are making the decision to initiate renal replacement therapy? And what tools do we have to help us discriminate whether patients are getting better or are getting worse? Certainly our clinical judgment is probably heavily weighted into that decision-making process, but I list a number of things there about the tools that we may or may have, or we may or may not use, but a lot of those haven't been carefully integrated into decision-making around the initiation of renal replacement therapy. So I want to spend the next couple of minutes just presenting a little bit of data from a trial that we've recently completed called the START-AKI trial, which was a multi-center randomized controlled trial of early accelerated initiation of renal replacement therapy compared with standard initiation of renal replacement therapy in critically ill patients with acute kidney injury. And this was a pilot trial in a large program of work aimed at doing a more definitive trial. So as mentioned, this was randomized open-label pilot study at 12 centers across Canada, supported by the Canadian Critical Care Trials Group. The inclusion criteria were adults admitted to ICU who had evidence of severe acute kidney injury based on two of the three following criteria. So we used a twofold increase in serum creatinine, or KDIGO stage 2, or relative oliguria. The third criteria that we integrated into this trial, at the time that we designed it, we wanted to be introduce an innovative and novel aspect, which was to use a kidney damage biomarker. In this case, it was serum NGAL, to help guide the decision-making around renal replacement therapy initiation. So that was one of our criteria that could be fulfilled. Patients had to have a lower likelihood of initiation of renal replacement therapy in the subsequent 24 hours. And this gets at the heart of equipoise around this issue. We're talking about the patients who are kind of in the middle, not patients who are clearly getting better and you know are going to recover based on your clinical judgment, and not patients who are clearly developing life-threatening complications related to their AKI. Right? These are the patients in the middle where, there's some equipoise around whether we should or should not initiate renal replacement therapy. We had a number of exclusion criteria, but once all these inclusion-exclusion criteria were fulfilled, we actually still had two further criteria. We went to the treating physicians or the providers and said, look, do you have equipoise to initiate this patient into the trial? And the physicians could veto it for two reasons. One is they felt it was absolutely mandated, and one was they felt that deferral was absolutely mandated. So here is a sort of a stop clause whereby the physician's judgment actually had some interaction with the decision around prescription of therapy, and it wasn't completely protocolized, right? So the attending physicians, in our view, had to have equipoise, otherwise the trial would not have been successful. And I can tell you about the data around those decisions thereafter. We had random block allocation. They were randomized to either accelerated initiation within 12 hours of eligibility, which included everything from getting consent to enroll from patients and surrogates, insertion of the line, initiation of therapy, versus standard initiation of therapy, which was basically watch and wait, and renal replacement therapy was discouraged unless any of the following criteria had occurred. And we followed them out until recovery or death, essentially. We screened around 1,800 patients. Ultimately, 124 fulfilled eligibility. We consented 101 and randomized 100 patients, and we had 100% follow-up at 90 days. Here you can see the baseline groups of the accelerated and standard arms. You can see average age is around 60. Importantly, around 50% of these patients were septic, which actually aligns with observational data suggesting that this is some of the most common reasons we see acute kidney injury in critically ill patients. And there was a scattering of other clinical factors as well. About a third actually were postoperative. Here you can see at the time of randomization, the biochemical profile of the patient. So the serum creatinine and urea levels, which interestingly are largely aligned with what we saw in the renal trial data. So this is fairly consistent. Patients were relatively oliguric. And I'll point out the SOFA scores. So the SOFA scores were high. These were, 13 to 12 to 14 range. These patients had multi-organ dysfunction. And you can see further down, almost all of them are receiving mechanical ventilation and, in fact, receiving vasopressor therapy. So this actually aligns with our preliminary work and observational data suggesting that these might be the patients we wanted to enroll in the trial who might have the most equipoise. I want to point out a couple of other things here. You can see the median plasma NGAL levels at the time of randomization. So everyone had an NGAL done, and you can see that the median value was exceeding the upper limit of the assay, more than 1,300. So this told us two things. One is plasma NGAL is probably not going to be ideal for screening for this trial because more than half of them had a level that was off the charts. But it was also reassuring to us that we actually identified a patient population that had true acute kidney injury and damage to their kidneys to some extent. You can see the actual average fluid balance as well was considerable, about 5 to 6 liters. So we randomized patients. All those in the accelerated arm, 100% of them got their therapy. In the standard arm, you can see about 75% of them either got their therapy or died within the first 14 days. So about 25% didn't receive therapy. This would mean that they actually recovered spontaneously. You can see the median times to initiate and the mean times to initiate therapy. There was about a day and a half difference between, so we had clinical separation in that respect. And you can see below, the second sort of table here is these are the factors amongst those that got initiated on renal replacement therapy. So it's informative to look to see what happened to those who got renal replacement therapy in the standard arm, what happened to their clinical parameters in the subsequent 24 to 48 hours. You can see that their serum creatinine went up, their ureas went up, they were more oliguric, they had accumulated more fluid, despite their SOFA scores staying about the same. So they had progression, if you like, in the complications and attributes associated with acute kidney injury. When we look at the outcomes, granted this is a pilot study, so it was not actually targeting mortality per se, but it was to inform a larger definitive trial. But our mortality was around 38% at 90 days. And that actually aligns pretty well with the Finaki observational data, that their mortality was around 37, 38%. And that's not too far off what we saw in renal, which was around 45%, if I recall. So amongst those surviving, though, only 2 patients needed renal replacement therapy, had progressed to end-stage kidney disease, and they were both in the standard arm. And I like to sort of draw attention and make an argument too, but recognizing this is only pilot data, but those getting accelerated renal replacement therapy seem to stay fewer days in the ICU. They seem to stay fewer days in hospital, perhaps. And they certainly had fewer renal replacement therapy sessions overall. So there's actually potentially a resource implication to this and any data that comes from subsequent work related to this. So not only outcomes, but in fact, it has to do with the bedside resources and how costly the therapy may be. What happened to the patients in the standard arm? We randomized 52, if you recall. 33 commenced. Importantly, only 1/3 ultimately had a classic indication at the time of renal replacement therapy. So to be honest with you, the providers in our study, both nephrologists and intensivists, were trigger happy. They were nervous about leaving these patients too long, and so only about 1/3 had developed a complication consistent with what we were asking for in the trial. 6 died, and 13 survived and did not need renal replacement therapy by day 14. Or did not receive by day 14, sorry. So about 1/4 overall actually recovered when we left them alone, right? And that's probably to be expected. So there is new data coming on this very question. The French have been very aggressive. They have 2 ongoing randomized controlled trials, probably competing with one another. But both of these may be done later this year or early in 2016, which is encouraging. Both are relatively small. They're specialized and focused, one on septic AKI alone, and the other is sort of a 4-arm trial looking at no renal replacement therapy as a wild type per se. But I can tell you that we have been developing the infrastructure and applying for funding. We've secured quite a bit of money to initiate a definitive START AKI 2 trial that we hope to initiate in Canadian centers by October. We have collaborated with colleagues in Australia and New Zealand who are looking to initiate pilot work in the next couple of months. We've collaborated with our colleagues in Scandinavia, the Scandinavian Clinical Trials Group, who are subsequently submitting an application for funding, and as well as in the U.S. So we hope to have a 70-patient trial up and rolling by early 2016 to mid-2016 to definitively inform on this question. So conclusions. The issue of when and in whom to optimally start renal replacement therapy is an important knowledge gap. I think the decision to start, as Dr. Mehta had clearly pointed out in one of his final slides, is very complex. There's a lot of modifying factors that go into this decision making. I would say that unnecessary renal replacement therapy, and Ravi did touch on this, may in fact impede or delay recovery and cause attributable harm in those with marginal indications. So that's something to be mindful of. Delayed renal replacement therapy may be associated with increased mortality. Certainly that's supported by observational data right now. Earlier renal replacement therapy may improve both survival and renal recovery, but again, it's largely supported by observational data, and I would argue that it's suboptimal, heterogeneous, and the risk to patients remains unclear and undefined. We do need better understanding of the current standards of care and determinations of practice variation, and then other things that we can do to risk stratify patients. So Dr. Chawla might give a talk on furosemide stress test as a dynamic barometer, if you like, of what kind of renal reserve patients may have, or microscopy, or the role of biomarkers is still really evolving, to be honest. So I think, concluding, we need further high-quality definitive trials to help inform practice on this important issue. Just want to acknowledge the START AKI team and all the resources and funding that went into our study to date. Thanks very much. I'll take questions.